I would call upon Dr. Tamanas Chaudhury to speak about complications of bariatric surgery.
Just a minute, you stop it, the video, please. Good morning, everybody. I am really thankful to share some of our experience and experience of our friends all across the country who have shared their videos. This is absolutely for academic purpose. There is nothing, it may be appears that some so kind of that are bad complications happening in these procedures. Complication is a part of life, part of surgery. So these all videos may sometimes arise not to discourage anybody, but to understand that what can be happen in some extreme situations. Already Dr. Sarfaraj mentioned something what happens in sleeves. Let's start the video, please. So I'll talk about sometimes when we put the staplers, it can happens to be some hematoma forms on the staple lines. Sometimes we just ignore it, but we cannot ignore every time, because it can happen because of too fast firing. It may come off after 7 or 8 days after with a leak of that areas. Particularly for sleeve, it is important what Sarfaraj mentioned, we work in a very high pressure tubes, because that reason this small hematoma may come for a ischemia or that area at may leaks. So better is whenever there is a hematoma, we must look upon it, manage it, then go ahead. Sometimes it can happen on the next day morning, the patient is not feeling good, the procedure was done day before, and there may be fall of hemoglobin more than 3 gram%. The drain may not, may give some sign, may not, but the patient's well-being and the hemoglobin low we should not be hesitant to re-explore, put the telescopes once again. So we must look once again, then we see there is almost 1 to 1.5 liter of blood all across, and there was a bleeding which was really one artery is bleeds from the stomach margin, and that to be sutured. We must be very careful. We should not apply any kind of energy sources on those areas to control. If we can put a clips, it's okay, but better to suture. And this is the second time if we re-explore, it is always better to put a suture, and it's a PDS 20 or if a Vacrel 20 is good enough to put on that areas, and we can suture it. And definitely we should suture slightly above and slightly below, so that we should not go for another exploration sometime after. So this is sometimes it happens, the surgeon is, there is a small bleed from the staple line, and surgeons put a bipolar to control that staple line. And the lessons we learned from that, the patient come back 7 days after with a leak of that areas. Because of that energy source, we put on the staple line, it's a metal, so it gets ischemic. Temporarily the bleeding stops, but subsequently the patient came back. It's a great learning for all of us. We should not do any kind of energy source if there is any bleeds from the staple line. It's a suture or clips. It can happen. We always say the bad sleeve, blood looking sleeve is good, but definitely we should not go for a worst looking sleeve. It can happen because of pulling of sleeve anterior part quite more, the posterior stomach is there. It can happen at the end, it is rotated. And if the rotation is there, if the spiraling effect happens on the sleeve, it is really a challenging on the next day morning when patient cannot take anything. We allow to take 50-60 ml of gastrographin to do the next day morning, but the patient really can't tolerate. It just vomited out. But when we should not wait till the next day morning, we should check on that day on table. If we look a bad sleeve, it's good, but not a worse sleeve. It is really spiraled. So we have to correct on that same times. It can happen if we are not that careful when we put the staplers. So it's better to stitch this posterior wall along with the posterior anterior surface of the pancreas. We can suture it in 3-4 areas, and it's always good what in demonstrating the procedure Sarfaraj mentioned, we should have put a bougie, and that bougie can guide us properly, and we should not pull any of the surface more, either anterior or posterior, then the spiraling effect can happen. So this technical error can happen sometimes, so we should not. So this is the corrective measures what we can do in if it happens. So when we put a sleeve, it is better So you should look properly. The bougie should go very smoothly. There should not be any, if there is any spiraling effect when you take out the bougie, again if we try to put it out, put it inside, it's good. But in our practice, we always do a leak test. So what happens when we put the liquids, it's really difficult. Even the solid can take its own shape, but if we put the liquids on that, it's difficult to pass on. Sometimes it can happen, the ROIGB, what Dr. Bhartiya told very clearly, we should close the mesenteric defect very carefully. Definitely, after doing the whole procedures, we should cover it. Sometimes surgeon may miss it, may not properly close. The patient may come back with a hernia in any time of life, even 3-4 months after, 6 months after, because when patient starts losing weight, the chance of this herniation is more. So we must close that defect very carefully. This is one of the patient who came with a severe vomiting, pain abdomen. After CT scan, we have seen there is a obstructions and there is a loop within the mesenteric defect, and that to be managed laparoscopically. And we have closed that defect after pull out these obstructions. Somehow we were lucky that the gut was not gangrenous, so we have no requirement of resection anastomosis, but at least we have to relieve the obstruction and close the defect. So this is the defect which was not properly closed at the time of surgery, and it was not that visible at the time of surgery, particularly because of the patient is obese that time. And in a subsequent time when patient is losing weight, this defect can grow more in size, and the possibility of hernia is more in subsequent times. So you must be very careful. So when you do the primary surgery, you must be very careful to close this defect. Implication is herniation and maybe fatal if we do not recognize these complications. So this is a rituals to close all the mesenteric defects properly in every ROIGB. And it should be very proper and it should be absolutely closed. Otherwise, these kind of implications may happen. This is one of the case where surgeons is doing the closing the defect very meticulously. So there is no possibility of subsequent hernia formation in this patient. So always the prevention is always best for this kind of. This is one of the situations where somebody is asked to put the bougie and in a sleeve. And the person who is putting the bougie, most of the time the theatre technicians, there was some, instead of manpower, maybe somebody has put the horsepower, and that bougie itself ruptures the esophagus. And that really one of the very dreadful complications, which is really one of the extreme situations. By bougie itself, there is a rupture of the esophagus. It is one of the situations really, I think this esophageal injury itself is one of the bariatric procedures. If somebody have a esophageal injury for any other surgery, person will lose so much of weight because of the healing process, go for TPN or the feeding jejunostomy, all these procedures to heal up, it is really person will lose so much of weight. So we must be very careful, very gentle when we manage this, putting this bougie. Particularly, we should not allow somebody very novice to put the bougie because most of the time the patient is covered with drips, they are blindly manipulating the bougie. So must be very gentle and must be properly lubricated. So these things should not be ignored. This is a very minor thing, but should not be ignored. Ultimately, the complication is too high. So managing this kind of esophageal injury is really a big challenge for anybody who happens. In ROIGB, sometimes it happens, we put in a circular staple, most of the time it happens. Dr. Bhartiya demonstrated very nicely the linear staplers. In earlier, most of the people we do with circular staplers, and one of the surgeon put the anvil, but after that he has not taken proper care, it is just go inside. Now the challenge to take it out is a big challenge. So this is the situation when try to put some bougie, push with bougie, something else, but it's really a big challenge. You must be very careful. If we put the Orwell, it should be hold with someone. We do not allow to retract. There's a possibility of that. There is other situations where these herniations, again I repeat, herniations is one of the big challenge in any of these procedures. Somehow in these same mesenteric defect is not properly closed, so these herniations happens. So slightly fast video, please. I can't manage it from here. Because I shouldn't. Yeah. This is another situations where there is a leak after sleeve gastrectomy, and this is one of the situations where really we must be very careful, particularly if there is any bleeds or something which is not taken proper care. Sleeve is one of the very challenging surgery. It may appear technically easy to do, but to manage a sleeve patient is very challenging, particularly for leaks. Sarfaraj mentioned to overlapping sutures. Earlier we put some seam guard, so many things we have tried, but in over a period of time, if a proper sleep is done and the patient is properly, staple line is managed, these kind of complications we may avoid. But one leak in a sleeve is really very difficult to manage, so it's always better to prevent this leak rather than allow the patient to leak. Thank you very much for your patient hearing. I'm just giving you some tip of the iceberg of the complications. The complications can be enormous, and I am sure every surgeon faces some amount of complication of their surgical life. So we have to manage properly of those complications. Thank you very much for your patient hearing. Thank you.
Thank you, Dr. Chaudhury. Excellent talk. I think you have touched upon the most common complications of bariatric surgery and the most dreaded ones. If there are any questions from the floor?
No
we'll move on.
complications. Thank you.